Hello students, it's Dr. Jami and our next topic is about acute cholecystitis. So what is acute cholecystitis? It refers to acute inflammation of gallbladder due to cystic duct obstruction. Due to cystic duct obstruction. So it is called acute cholecystitis. So the same is the epidemiology. If you have covered my cholelithiasis and choledocholithiasis topic, you know everything almost about cholecystitis too. So most commonly in females more than males. So usually peak incidence age is more than 50 years. So we are going to discuss what causes acute cholecystitis. What is the etiology? We are going to discuss. So this is going to be a very to the point lecture. So first is acute calculus cholecystitis, and the next cause is acalculus. Acalculus cholecystitis. So what is acute calculus cholecystitis? It is caused by obstructing cholelithiasis. If there are stones in gallbladder, it leads and these are presenting with obstruction like obstruction of neck or common bile duct. If there is obstruction and leads to obstructive symptomatic cholelithiasis, so it will leads to acute calculus cholecystitis. So what is the pathophysiology behind this obstructive cholelithiasis? When there is cholelithiasis, the stone passes into cystic duct. So when there is the stone in cystic duct, there is obstruction. So this obstruction leads to distension and inflammation of gallbladder. So there will be forceful contraction but no release of bile. So bile keeps storing in it or bile keep producing in it. There will be mucus production inside the gallbladder, which leads to distension and ultimately leads to inflammation, as there will be bacteria which start producing their effects. So next cause in next acute calculus cholecystitis cause pathophysiology is secondary bacterial infection. So what happens if patient may also have bacterial infection presentation. So but it is not necessary to develop cholecystitis due to these bacteria like E. coli, Klebsiella, Enterobacter, and Enterococcus species. So it is not a most common cause, so we are not going to discuss it. So next risk factor was acalculous cholecystitis. So about 5 to 10% of acute cholecystitis patients are acalculous cholecystitis. So we have studied the etiology. Now we are going to discuss about the clinical features. How a patient is going to present to us, what will be his complaints. So patient comes to us with right upper quadrant pain. So you know that gallbladder is present in right upper quadrant. So patient comes to us with right upper quadrant pain and you ask about the severity of pain. Patient tells you that the pain is more severe and prolonged. So in cholelithiasis, the pain is usually of not more than 6 hour duration. In choledocholithiasis, the pain is severe and prolonged, like more than 6 hours. Same in here. In acute cholecystitis, the pain is prolonged more than, or duration is of more than 6 hours. So associated with food intake or not? Yes, it is associated with food intake. Postprandial, I told you that you have understand everything about cholecystitis in previous video, so I am going to skip the explanation. So now you will ask about the radiation. In cholelithiasis, the pain is radiating towards the epigastrium region or to right shoulder and to back. So here what happened, the pain radiates to right scapula. Why pain refers to right scapula? Due to phrenic nerve irritation. Phrenic nerve irritation. This is also a referred pain. So next thing is, next clinical feature, you palpated the gall, you try to palpate gallbladder. There is sudden and you there will be tenderness or pain, so you will elicit positive Murphy sign. So what is positive Murphy sign? So you on when we are palpating the patient, palpating the abdomen, and you ask about to inspirate and expirate. During inspiration, the abdomen distended a bit. So what will happen, you do not push your, you do not palpate in aspiration, but during expiration the abdomen becomes flat. So what will happen, when you push your, when you palpate the gallbladder by using your hand, the your hand touches the gallbladder, patient will stop his inspiration. So what will happen during inspiration, when your hand touches the gallbladder, patient stops his inspiration. There will be a sudden pausing of pausing during inspiration. This is called positive Murphy sign. So next clinical feature is guarding, and next clinical feature is fever, malaise, and anorexia. Nausea and vomiting can also be present. So this is the clinical presentation. A patient comes to you with right upper quadrant pain, and which is, the pain is very very severe, and duration is of more than 6 hours with nausea and vomiting, and you palpated the gallbladder and try to palpate the gallbladder, there is positive Murphy sign, and there they, and you ask about that patient if the pain is radiating towards any part of your body, and he tells you that patient that the pain radiates to right scapula, and pain is associated with food intake. After food intake, pain is usually worsens or increases in intensity. So that's how a patient comes to you with clinical presentation. So what are the subtypes and variants of acute cholecystitis? So we are going to touch it a bit. So what are the variants or subtype? First is acute acalculous cholecystitis. What happen, there is a no calculi, no stones in gallbladder. So what happens, it is a life threatening necroinflammatory disorder of gallbladder. Usually those patients which are chronically ill presents with acute acalculous cholecystitis. So what is the etiology of this subtype? Usually the first risk factor of such patient is multi-organ failure, a critical ill patient, so or a patient of severe burns or trauma. So next risk factor is surgery. Infections can also lead to acute acalculous cholecystitis. Infections. So viral infection, cytomegalovirus, can lead to acute acalculous cholecystitis. A patient of sepsis or a patient in shock can have acute acalculous cholecystitis. A patient on total parenteral nutrition can also have acute acalculous cholecystitis. So, how patient presents to us with acute acalculous cholecystitis? The clinical presentation will be same of calculus cholecystitis. So, we are going to study about our next subtype. Next, first one is acute acalculous, second one is emphysematous. I am touching these points lightly. So emphysematous cholecystitis EC. So it is also a rare but life-threatening form of acute cholecystitis. What will happen? There is air within the gallbladder. When there is air in gallbladder and the cause is that is caused by bacteria which are gas forming like Clostridium species. Gas forming bacteria present in gallbladder producing air within the gallbladder is called emphysematous cholecystitis. It is also a form of acute cholecystitis. So what will happen in 70 years old man with diabetes come to you with right upper quadrant pain? What will you investigate? You will investigate its right upper quadrant structure. So, what is the pathophysiology behind development of gas in gallbladder? So, there is vascular compromise in gallbladder. There is a vascular compromise like ischemia, vascular compromise in gallbladder. So, what will happen? There will be occlusion of cystic artery leads to ischemia. This ischemia of gallbladder wall, as you know, there is ischemia which further leads to development of necrosis. This necrosis leads to proliferation of in dirty places dirty organisms grow. So in necrosed part there will be proliferation of gas forming bacteria. So where is necrosing take place? Necrosing is take place in the gallbladder wall or lumen. So there is proliferation of gas forming bacteria and production of gas leads to emphysematous cholecystitis. So what organisms can form gas? First species you have to remember is Clostridium. Next is E. coli. Clostridium or E. coli. These are most common. So what is the risk factor? As I already told you that a old patient with diabetes comes to you, first risk factor is diabetes. Next is a patient who is immunocompromised or immunosuppression with low immunity. So next risk factor of development of emphysematous cholecystitis is any vascular disease like atherosclerosis, embolism or vasculitis. And the last risk factor is patient comes to you after abdominal surgery or trauma. So the clinical presentation will be same of acute calculus cholecystitis. There will be fever and right upper quadrant pain and referred pain to right scapula. So we these are the subtypes. So next point is how we are going to approach for diagnosis. Where is yellow color? So let's use this. So how we are going to approach for diagnostics? So diagnostic is based on clinical features as I already told you. As it is the inflammation of gallbladder, we are going to find systemic signs of inflammation. What systemic signs? First of all, you have to evaluate that inflammation is present or not. First thing is CBC. So next is right upper quadrant transabdominal ultrasound. The same pattern we are going to use here. Initial evaluation. So what we are going to do, we are going to perform CBC and transabdominal right upper quadrant ultrasound. So what is the diagnostic criteria? Let's study about diagnostic criteria. There is a criteria for diagnosis. Diagnostic criteria. There are three criteria which tell us that there is either acute cholecystitis or not. So if there are local signs, what are local signs? Positive Murphy sign or right upper quadrant pain, tenderness, or you feel a mass. If you got these local signs, then it is a positive diagnostic feature of acute cholecystitis. Next thing is systemic signs. For systemic signs, you check fever, you check CRP levels, and you check leukocytosis. If any of these signs is present, it is a positive diagnostic indication of acute cholecystitis. Next thing is you done imaging. So after ultrasound, you find emphysematous cholecystitis or any imaging modality like distended gallbladder, thickening of gallbladder wall, positive findings. So how will we interpret this diagnostic criteria? So interpretation is, if patient comes to you with one or more local signs of inflammation plus one or more sign of systemic inflammation, it is a suspected diagnosis. You are suspected of acute cholecystitis. So if a patient comes to you with more than one local sign plus more than one systemic sign plus you found characteristic findings on ultrasound, finding on imaging, it is a definitive strong definitive criteria. So that's how you're going to interpret that patient is a case of acute cholecystitis. So what we are going to do, we are going to perform where is I am going we are going to perform CBC, and what will we find in CBC? We will find leukocytosis, number of white blood cells will be raised. But in 40% patient, you have to keep your mind sharp. In 40% patient, it can be normal. So do not rely on CBC thoroughly. So next thing you are going to check, patient is having inflammation, we are going to check CRP. It will be elevated in a case of acute cholecystitis. Next thing we are going to check is blood culture. So there is a grading of acute cholecystitis, grade 1, grade 2 and grade 3. If a patient comes to you with grade 3, like this very severe symptoms comes to you, you have to check for blood culture. So what else you have to do? If a patient of grade 3, not mild, not moderate, patient comes to you with severe acute cholecystitis like grade 3 patient comes to you, you have to do his bile culture too. So in order to assess the severity, we do blood gas analysis, we do basic metabolic panel, either the acute kidney injury is present or not. We'll see electrolyte derangement in BMP. With severe disease, we'll check liver function like prothrombin time, prothrombin to INR ratio to check coagulopathy. In severe cases, there is coagulopathic disease in such patient. So we'll rule out next. We'll rule out test to rule out related biliary comorbidities. So we'll perform LFTs. So what will happen if there is biliary comorbidity? There will be raise in AST and ALT levels, but these levels may be mildly elevated. So this is as also a positive finding of biliary related comorbidity of acute cholecystitis. So next thing we'll look for signs of cholestasis. What are the signs of cholestasis? Jaundice, pruritus, and on lab investigation, what will be we'll find high bilirubin level, high ALP, and high GGT. These are uncommon findings in acute cholecystitis. So if you can skip it. So next thing we are going to check is, as our criteria is to check everything in right upper quadrant, like liver, like pancreas enzyme, lipases, amylases. We're going to check these enzymes. If there is elevation of elevated level of amylase but not mild elevation, there is mild elevation of amylase, it also indicates acute cholecystitis. So if a patient comes to you with more than 3% or more than 3 times of normal of lipase or amylase, like if the normal value is 5 and patient comes to you with 20 international unit of lipases, I am giving you the example. So it indicates acute biliary pancreatitis if the values are more than or equal to 3 times the normal. So that's how we are going to approach right upper quadrant pain fever. So next thing is we are going to perform imaging. So first imaging we are going to perform is right upper quadrant transabdominal ultrasound. So what will we find? We will find gallbladder wall thickening in acute cholecystitis. Next thing is we will find gallbladder distension. So third finding on ultrasound will be gallbladder wall edema. So how will we differentiate? There will be two walls of gallbladder and which are hyperechoic. You are getting it, hyperechoic, two walls with hypodense areas. The center area will be hypodense, which indicates edema. So the next thing is when you press the probe on gallbladder site, there will be positive Murphy sign or sonographic Murphy sign. When probe touches the gallbladder, there will be tenderness, sonographic Murphy sign. So what else we can find on right upper quadrant transabdominal ultrasound? Pericholecystic free fluid. On undergrad level, patient comes to you with you have given scenarios with the clinical features and some typical findings on laboratories. So these findings are for post graduation level students. So what else we can find as the risk factor is calculus cholelithiasis or as the risk factor is cholelithiasis of acute cholecystitis, we will find stones in gallbladder also. So these are the our gallbladder findings on ultrasound. So we have, if you become a radiologist, you have to check common bile duct to see whether there is any stone in CBD or not. That's it is also a very crucial step. So next thing is HIDA scan, cholecystography. So hepatobiliary amino diacetic acid scintigraphy or HIDA scan. So it is preferred confirmatory test for uncomplicated acute cholecystitis. If you could not conclude from your ultrasound investigation, you will go for HIDA scan. So what is the advantage? It is highly sensitive and specific. So it is also considered gold standard test to diagnose acute cholecystitis. So what will we find? We'll find when we give a radioactive tracer within 4 hours, in normal gallbladder, you give a radioactive tracer. If the gallbladder is normal, it will be visualized within 4 hours. If a patient of acute cholecystitis comes to you and you give radioactive tracer in acute cholecystitis, so you give radioactive tracer, and in acute cholecystitis what happens, gallbladder is not visualized. You will not be able to visualize gallbladder within 4 hours. So this is the finding on within 4 hours you will not visualize gallbladder. So this is the characteristic finding of acute cholecystitis diagnostic test. Next test we can perform is MRI abdomen with or without contrast. With or without contrast. So the findings will be same of ultrasound finding. Next we can perform CT abdomen with IV contrast. So if there is not a facility to do HIDA scan or MRI, and you are suspecting that patient is of acute cholecystitis and there will be inconclusive findings on ultrasound too, so you will go for CT abdomen. So if a patient comes to you with emphysematous cholecystitis and you are suspect, and patient having risk factor of emphysematous cholecystitis, you will advise CT abdomen with IV contrast. So if patient comes with complications of acute cholecystitis, you will advise CT abdomen with contrast. What will you find? The same finding that you will find on ultrasound scan, you will get on CT abdomen. So what is the severity? We are going to grade the severity. Grading, let's make it thick. Grade. If a patient comes to you with grade 1, how will you check that patient is of grade 1, grade 2 or grade 3? So if a patient comes to you with no organ dysfunction, no organ dysfunction, his liver is working fine, his pancreas is working fine, his gallbladder is producing enough gallbladder, and there will be no signs of cholelithiasis, cholelithiasis or inflammation, no fever or any other systemic complication. So you will put him in grade 1. It also tells there is mild acute cholecystitis. So if a patient comes to you with moderate acute cholecystitis, so in moderate acute cholecystitis there will be no evidence of organ dysfunction, but there will be presence of at least one clinical feature like symptoms of acute cholecystitis with a duration of more than 72 hours present. So you check patient's white blood cell count and it is raised, WBC count raised to more than 18K per millimeter cube. So you try to palpate gallbladder or right upper quadrant and there will be tenderness, palpable tenderness in right upper quadrant. If there is any clinical feature, any feature of biliary disease is present, you will place the patient in grade 2 moderate acute cholecystitis. So what will happen in grade 3? There will be severe acute cholecystitis. There will be dysfunction of organ system, at least one organ system, like CVS hypotension, impaired consciousness, respiratory problem, like there will be uh, oxygen depletion, or there will be some renal abnormality, or there will be coagulopathy, or patient comes to you with low platelet counts. This will indicate dysfunctional organ system. So we'll put the patient in severe acute cholecystitis. So we are going to treat the patient according to the grading or severity. So first of all, the main the main treatment plan is main treatment plan is antibiotics plus surgery, cholecystectomy. So the main treatment plan is antibiotic plus cholecystectomy. So if a patient comes to you, you will manage. How you will going to manage? We will going to evaluate patient whether there is any sign of sepsis or shock present or not. So we will going to screen for sepsis or shock. That's how you going to approach a patient. Next is, if a patient comes to you with acute biliary infection, you are going to start antibiotics immediately. So we are going to, if there is signs of biliary disease, as bile is stored in gallbladder, you have known the function of gallbladder. So bile is stored, as if patient comes to you with biliary disease, we will provide initial support. What initial support we discussed in cholelithiasis? We give patients bowel rest, nil parolar, bed rest, fluid resuscitation, analgesics, spasmolytics, and antiemetics. Initial support. So if a patient, so and then we consult surgeon for operation. So what is the definitive management? The definitive management, I told you, that is cholecystectomy. Definitive management. Definitive management is cholecystectomy. Removal of gallbladder. So if a patient comes to you as early as possible and you have a laparoscopic surgeon available, you will go for laparoscopic cholecystectomy. The next procedure we can perform is gallbladder drainage. So how it is going to perform? We going to perform it percutaneously. Percutaneous cholecystectomy. cholecystostomy. It is a temporary measure for those patients who are unstable or grade 2 or grade 3. It is a temporary measure. Percutaneous cholecystostomy. So if a patient comes to you with grade 1 acute cholecystitis, so and he is a low surgical risk patient, we will perform early laparoscopic cholecystectomy. And after cholecystectomy, usually there is no need for postoperative antibiotics. And if a patient is high surgical risk patient in grade 1 low surgical risk lap chole as soon as possible. And high risk patient, you are going to perform early laparoscopic cholecystectomy, plus you will give post operative antibiotic, but you will discontinue antibiotics after 24 hours of surgery. Or you can give some conservative approach in a high risk patient, like you can continue giving antibiotics until symptoms improve, and then we'll arrange interval cholecystectomy. So if a patient comes to you with grade 2 acute cholecystitis, and you try to give initial management and patient's condition improves, now patient is in low surgical risk group, and or patient may be of high surgical risk group. So if a patient is of low surgical risk group, we will perform lap chole, laparoscopic cholecystectomy. And in these patients, the same protocol is followed, that will discontinue antibiotics after 24 hours of surgery. So if a patient of grade 2 with high surgical risk group patient comes to you, we will give antibiotics until symptoms improve, then we will give interval cholecystectomy. So a patient comes to you with grade 2 acute cholecystitis and his symptoms are deteriorating while you are giving the initial management, symptoms are not improving, what will you do? We will perform urgent gallbladder drainage. As I told you that it is a temporary measurement of grade 2 and grade 3. Then we perform interval cholecystectomy, and then for 7 days we give antibiotics. So that's for grade 2 patients of acute cholecystitis. So in a grade 3 patient or severe acute cholecystitis patient, if patient is a low surgical risk, patient is in a low surgical risk group, we will give early laparoscopic cholecystectomy. Like first, a patient comes to you with severe acute cholecystitis. In all cases, you have to give initial management, you have to stabilize the patient, then you perform surgery. So in grade 3 acute cholecystitis, the patient is in low surgical group, you give initial management, patient's symptom improve, and then you perform early laparoscopic cholecystectomy. Then you continue antibiotics for 4 to 7 days after surgery. And in grade 3 patient is of high surgical risk. In highly surgical risk means you perform a surgery and there is development of patient is not stabilized, patient is not a good candidate for surgery. First thing is that there are risks associated with the development of hemorrhage, development of abscess, development of hypotension or anesthesia complications. So if a patient is not able to tolerate surgery, he is a high surgical risk. If a patient is good in overall health and can tolerate surgery easily, he is a low surgical risk patient. Or if a patient of grade 3 in high surgical risk group comes to you, what will we do? We will urgent gallbladder drainage, then we'll do interval cholecystectomy, plus we admit the patient and observe him for any complications, and will continue antibiotics for 7 days. So laparoscopic cholecystectomy is a gold standard treatment of acute calculus cholecystitis. So if a patient comes to you, early laparoscopic cholecystectomy means a patient comes to you and you perform it within 10 days of symptoms onset. Within 10 days of symptom onset, and patient comes to you and you perform it within 24 to 72 hours. This is called early laparoscopic cholecystectomy. And what is interval laparoscopic cholecystectomy? A patient comes to you and you give initial management, then you give medications, then you perform laparoscopic cholecystectomy after interval lap chole after 45 days. You try to resolve the clinical features, clinical symptoms of patient by managing patient, and then after 45 days you perform laparoscopic cholecystectomy. It is called interval laparoscopic cholecystectomy. Like after 40 days of resolution of symptoms, you performed laparoscopic cholecystectomy. It is called interval or delayed lap chole. So what are the next option we are using in grade 2 and grade 3? Patient comes to you with a patient of high surgical risk comes to you of grade 2 and 3, you provide temporary measurement. What is temporary measurement? We discussed gallbladder drainage. So there are two methods. First is percutaneous and second one is endoscopic. In endoscopic, we place a gallbladder stent and we uh, do drainage of bile. So it is a expert required. An expert is required in such procedure. Percutaneous, it is performed under ultrasound imaging. So there is a catheter is placed in gallbladder, and under local anesthesia bile is drained out. So that's how we give temporary measurement. So what antibiotics we can use? First we are going to perform blood cultures. Antibiotics, if a patient, so after blood culture and bile culture, you rule out that what kind of bacteria are causing inflammation. So we'll give antibiotics specific to that bacteria. So required coverage should be gram negative coverage plus anaerobic coverage, anaerobic plus enterococcus species coverage. So in grade 3 community acquired or healthcare associated infection, we will give enterococcus species coverage antibiotics. So what will be your choice of antibiotic in patients? In grade 1 you will give you if a patient comes where is if there is community acquired biliary infection and patient of grade 1 comes to you, you will give cefoxitin, you can give moxifloxacin, you can give ampicillin plus sulbactam. So you can give these drugs in community acquired biliary infections, and the alternative drugs you can give is metronidazole plus cefazolin. Alternative drugs cefazolin or ceftriaxone or ciprofloxacin. It's enough to remember. So if a patient comes to you with community acquired biliary infection and grade 2 symptom of grade 2, what will you give? You will give piperacillin tazobactam, or you can give moxifloxacin, or you can give ertapenem. Alternative drugs you can give in grade 2 patients of community acquired biliary infections is metronidazole plus you can give ceftriaxone or cefotaxime and cefepime. So you have to remember these are all cramming things. So if a patient comes to you with grade 3 severity, you will give piperacillin tazobactam, you can give meropenem, you can give ertapenem. Alternatively, you can give metronidazole. Stylus stopped working. Metronidazole plus cefepime or ceftazidime. Yes, I remember these. Cefepime or ceftazidime. You can give these drugs, antibiotics in according to severity. So if a patient, so what kind of complications can arise? Complications can arise. Acute cholecystitis can lead to gangrenous cholecystitis. It can perforate. There can be development of pus in gallbladder empyema, gallbladder pyema, distended pus filled gallbladder, or it can lead to chronic cholecystitis. These are the complications which can develop if there is no acute cholecystitis treatment. That's all about acute cholecystitis. Thank you so much.